delta wave.
No, delta wave's a delta wave. What is Wolf Parkinson White?
The bypass.
Okay. So these patients are more prone to what type of cardiac tachycardias? Okay. What does a delta wave look like? Slurring upstroke or downstroke, depending on which way the QRS goes. And because of that slurring, it shortens the PR interval. What is an Osborn wave or J wave? Same thing. What does it mean? Hypothermia. Osborn waves. 12 leads. I'm going to throw a bunch of questions real quick here, but they're all basically the same format. Lead 1 views what side? Lead 2 views what side? Lead 3 views what side? AVR views what side? AVL, AVF, V1, V2, you know, what does each lead view? There's specific questions if you get them. I'd say like, V3 views what part of the heart? You know.
Bless you.
Bless you.
Limb leads and chest leads. Chest leads are also known as precordial leads. Okay. So what does the precordial leads view? What parts of the heart?
Sally.
Not Sally. Sal.
Sal.
They do not view the inferior, the bottom. What does anatomically contiguous mean? Two or more leads that view the same area. Just like there was questions, what is lead 1, V1, yeah, blah, blah, blah. There's going to be questions like you see elevation in leads 1, V5, and V6. That is what part of the heart? Yeah. So I'm not saying that was the question. Just an example. 3 coronary arteries. You have the right coronary artery and then the left, which splits into the left circumflex and anterior descending. Please review what parts of the heart they perfuse, they supply. What is a pathological Q wave? What does that mean? 1/3 the height of the R, or more than one box, more than 0.4 seconds wide, and it shows previous heart damage, previous ischemia. What is a prolonged QT interval? And what would cause the QT to get longer? And I'll give you a hint on that one. It has to do with the electrolytes. Sodium, potassium, calcium, magnesium. What makes it get longer? More than just magnesium. I'm hearing a lot of guesses. Somebody said it. It has to do with electrolytes. All right. So do you remember how to determine axis? Like normal axis, left axis deviation, right axis deviation. We look at lead 1 and lead
2.
AVF.
AVF.
Okay. So if I was to say like it is positive in lead 1 and positive in AVF, that would be a normal axis. If it was positive in 1 and negative AVF, to the left. What is a left bundle branch block? How do you find it on an EKG?
Oh, that's the turn signal stuff.
Turn signal stuff, there you go. What is the turn signal stuff? Correct. The terminal end of the QRS. So remember, wide QRS, proof that it came from not the vent hypertension. So it had to be a P wave of some kind. So it's not a ventricular, it's a bundle branch block. So proof that it was, so P wave, wide QRS, which lead do I look at? V1. Last part of the QRS, if it points down, it's left, if it points up, it's right. What is LVH? What is reciprocal changes?
Mirror each other.
Mirror image. So, for example, if I saw ST depression in leads V2, V3, V4, because those cameras are looking this way, right? On the backside, the camera's looking in this way, like posterior, I could see ST elevation, mirror image. So, what is ACS?
Acute coronary syndrome.
All right. STEMI and NSTEMI. Okay, what that means. And NSTEMIs, just so you know, they don't usually take them to the cath lab. Kind of just let them run their course. Angina, stable and unstable. What was that thing when they like clutched their chests?
Levine sign?
Levine sign, yeah. Tell me about the pain of a heart attack versus a non-heart attack. What is it? How's it different?
Doesn't change when you take the breath.
It doesn't change with breathing. It's more squeezing, aching, dull, weight-like as opposed to sharp and stabbing. Okay. Somebody having a heart attack feels dizzy. Why? Decreased cardiac output. We talked a little today, anginal equivalents. Dizziness, weakness, nausea. Oxygen. We want to give oxygen to keep their sat above 94. What's my dose for aspirin? What's my dose for nitro? Reperfusion therapy. Right? It's going to happen at the hospital. What is the two options, basically? Reperfusion therapy. Somebody said one of them. Thrombolytics and cath lab. What's the biggest risk of giving someone thrombolytics?
Lead out.
Bleeding. Break up all their clots, right? PCI, percutaneous coronary interventions, is the cath lab. So just signs of right side heart failure, signs of left side heart failure. Treatment of left ventricular heart failure. A ventricular assist device, most commonly called an LVAD, left ventricular assist device. What do they do and what is a little weird about them? No pulses, right? Because it's not a pulsating movement of blood, it's a continuous movement of blood. Treatment for cardiogenic shock. What is an aortic dissection? What is hypertension? What causes hypertension? What is a hypertensive emergency? Remember, I wrote those numbers down there, our difference. Did not talk about this, you can read this one in the book. Hypertensive encephalopathy. So hypertensive means what? High blood pressure, encephalopathy. Within the brain, the pressure is so high that the fluid is leaking into the brain, causing the brain to swell. contraindications for clot busters. Definitely know your contras for nitro. There are some, for lack of a better, scenario-based. Right, like the guy has chest pain, his blood pressure's 110/70, 12 lead looks normal. You know, he has a history of cholesterol problems, he takes Lipitor and Cialis. He's already taken baby aspirin, what should your next treatment be?
Oh, he took it.
He takes Cialis.
Oh, never mind.
Severe pain between your shoulder blades, probably aneurysm. Right. I mentioned this the other day, but just to remind everybody, the national goal, they call it door to balloon time for STEMI. When we hit the door to the emergency room, they're in the cath lab having the procedure done, the balloon cath. The national goal is
60 minutes.
90 minutes. Right. I don't have the most current data, but most of the hospitals in Volusia County are under 30, so did very well here. What is chlorpulmonol? What is myocardial ischemia? So just to make sure everybody understands this word, palliated. So pain is palliated by, it means the pain decreases, gets better. You know, so what would make chest pain, you know, palliated? Nitro, oxygen, rest, you know, as opposed to provoked, which makes it worse. There are questions about the electrical conduction system of the heart. The normal pacemaker, where you put the actual leads, where V1, V2, V3, you know, like the descriptions of them. What is aberrant conduction? What is atherosclerosis? What is pitting edema? What is it a sign of? What is atrial kick? There are questions on ECGs like, you know, what's a normal PR interval? How wide should a QRS be? You know, things like that. There is at least one question on ST elevation mimics. Like left bundle branch block could be a mimic.
Mm-hmm.
You know, there are more than just left bundle branch block though. So in addition to, I'm sorry, I'm in chapter 40 now. In addition to high quality CPR, we really need excellent CPR. What is the next most important thing that has made a huge impact on cardiac arrest? Fibrillation, early defibrillation. How does your CPR change when you have an advanced airway? We don't pause for breathing. Okay. Just so we're all clear, advanced airways means anything more than an OP or NP. So all your King tubes, digels, things like that are advanced airways, not just ET tubes. Why do we not defibrillate asystole? Nothing to shock. Okay. There are some questions on the, for lack of a better term, ACLS treatments. All right, this person's in VFib, you shocked him, started CPR, you administered 1 milligram of epinephrine, you now shocked him again, continued CPR, the next drug you would give is? What is PEA? Questions about mechanical CPR devices? What is ROSC? Take that question. There's several like cardiac arrest scenario questions. So I talked a little bit about this today. With limited resources, working a code, what is one of the best situations for what is the best situation for the team? Not do anything. If you had to do something, what should you be working? Monitor. Interpreting the EKG, hitting the defibrillator button. I get there may be times you're doing other stuff too, but really if you have to do something, the best is just the monitor side. So we use the term therapeutic hypothermia, but ACLS calls it targeted temperature management. When would we do that? What patients would we do that to?
Shocky patients?
Cardiogenic shock. All right, we got ROSC, but they are not waking up. They're still comatose. Why is hyperventilation bad in cardiac arrest? Not for cardiac. It's bad in cardiac arrest because it puts pressure in the chest. You don't get fluid back to the lungs or back to the heart. Many questions on high quality CPR. Rates, depths, ratios, etc. And then chapter 41. What is a peri-arrest condition? What do we mean by that?
Pre-code.
Pre-code, yeah. So of the choices, which one would you say is a peri-arrest situation? It's quite obvious. Without reading the questions, a stubbed toe, a person whose blood sugar is a little high, a person with multiple single episodes with a blood pressure of 40, a person with an infected finger. Pretty obvious. So there is, if you randomly get this question, you have to calculate mean arterial pressure. What is preload? What is afterload? What is the Frank-Starling mechanism? What is the most common cause of cardiogenic shock? It's in the name. Something with the heart, right? Yeah. Stents, heart attacks. Alpha and beta stimulation. Like what does alpha 1 do, alpha 2, beta 1, beta 2? What does epinephrine do? And some H's and T questions. Those are very, 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 very good. Study that. I would be happy to review these again.